Welcome to the deep dive. Today we're zeroing in on a set of arterial conditions that, well, every vascular surgeon really needs in their toolkit, even if they're not as common as your typical atherosclerosis.
Yeah, we're talking about non-atherosclerotic arterial diseases.
Exactly. Think of this session as a kind of concentrated high-yield guide pulled directly from the definitive text in our field.
Right. We spent a lot of time in section 21, chapters 138 through 145 of Rutherford's Vascular Surgery and Endovascular Therapy, the 10th edition. And our goal really is to synthesize all that information from these chapters into something like a practical instruction manual, give you a structured, sort of immediately usable understanding of these less common but absolutely critical arterial challenges you might run into.
Okay, let's unpack this practical guide then. Starting with chapter 138, it really lays the groundwork on vasculitis syndromes. Now, at its core, vasculitis is, well, it's inflammation of the blood vessels, right?
Simple definition, complex reality. And Rutherford uses the Chapel Hill classification, which is honestly a crucial framework for how we start to categorize these really diverse conditions.
Well, quite a spectrum, isn't it?
Oh, absolutely. The chapter meticulously breaks it down: small vessel, medium vessel, large vessel, and then variable vessel vasculitides.
So starting with the small vessel ones.
Yep. Within that, you've got the ANCA-associated vasculitides, so granulomatosis with polyangiitis, that's GPA.
Used to be, we did ours are.
Exactly. Then microscopic polyangiitis, MPA, and eosinophilic granulomatosis with polyangiitis, EGPA.
Okay, so if you're facing a potential GPA case, one of the key clinical clues is often that upper respiratory tract involvement, isn't it? Like sinusitis or maybe a saddle nose deformity.
That's a classic sign. And the lab testing usually comes back showing CNCA with PR3 specificity. Treatment-wise, the standard is generally steroids combined with either cyclophosphamide or, increasingly, rituximab.
And then for MPA, how does it differ?
Well, with MPA, you might still see that pulmonary renal syndrome, lung and kidney issues together, but the upper respiratory tract problems, usually absent.
Oh, okay.
And lab-wise, you're more likely looking at pan-CA with MPO specificity. If you get a renal biopsy, it often shows what's called Pauci immune glomerulonephritis, basically few or no immune deposits.
And treatment.
Treatment approach is pretty similar to GPA, actually. But it's important to remember the prognosis can sometimes be a bit more challenging, maybe higher rates of relapse or patients needing dialysis down the line. Something to keep in mind.
Got it. Then there's EGPA, formerly Church-Strauss. What makes that one distinctive?
Well, first off, it's rarer, and it has this really strong link to both eosinophia, high eosinophil counts, and a history of allergy or asthma.
Interesting.
Yeah, and the clinical course can be sort of triphasic. It might start with allergic symptoms, then an eosinophilic phase, and finally the vasculitic phase. And here's the slightly weird part. The asthma symptoms can actually improve during the vasculitic phase.
Huh. Counterintuitive.
A bit, yeah. The ACR criteria are really invaluable for nailing down this diagnosis.
Okay, shifting focus then. Medium vessel vasculitis.
Right. Polyarteritis Nodosa, or PAN. This is characterized by a necrotizing inflammation tissue death in medium-sized arteries.
And a key feature here is?
A key distinguishing feature is that PAN typically spares the glomeruli in the kidneys, and it's ANCA negative. Diagnosis often relies on the ACR criteria,
Which include things like?
things like unexplained weight loss, that sort of net-like bluish skin discoloration, livida reticularis, testicular pain, nerve issues like mononeuropathy, and abnormalities you'd see on angiography.
And the cause. Can we pinpoint it?
Sometimes it's idiopathic, meaning no clear cause, but it can also be associated with hepatitis B infection. Other viral links have been suggested too.
Like lab tests.
Well, there aren't specific markers for PAN itself, but inflammatory markers are usually up. And checking for hepatitis B is absolutely crucial. Clinically, a really key point to remember for distinguishing it from those ANCA vasculitides we talked about is the lack of lung or upper respiratory tract involvement.
Makes sense. And treatment.
If it's Hep B related, antivirals are part of the plan. For more severe cases, you might use induction therapy with steroids and cyclophosphamide, perhaps followed by maintenance drugs like azathioprine or methotrexate.
Okay. Chapter 138 also covers large vessel vasculitis, right? Primarily giant cell arteritis, GCA.
Exactly. Now, it's actually rare for the intracranial vessels themselves to be directly involved. They lack a specific layer, the internal elastic lamina, but the internal carotid and vertebral arteries can be affected, and that can potentially lead to serious neurological problems, stroke, seizures, hearing loss, things like that.
Diagnosis. Still the ACR criteria.
The 1990 ACR criteria are still essential. Things like new onset headache, tenderness over the temporal artery, a high ESR erythrocyte sedimentation rate. Sensitivity and specificity are pretty good, but it's worth noting that ESR can sometimes be normal. So clinical suspicion remains vital. Don't rule it out just based on a normal ESR.
Good point. Okay, now onto the variable vessel category. This seems a bit like a catch-all.
A little bit. Rutherford groups thromboangiitis obliterans, or Buerger's disease here,
Yeah.
even though it wasn't in the original Chapel Hill list.
We'll come back to Buerger's in more detail, I think. What else is in this group?
Cogan Syndrome is another one. It can affect large and medium vessels, sometimes looking a bit like Takayasu arteritis.
Yeah.
The defining features are inflammation of the cornea, interstitial keratitis, vestibular dysfunction causing balance issues, and hearing loss.
Eye and ear problems.
Exactly. And what's notable is that these often develop within, say, 1 to 6 months of each other. You might also see systemic symptoms like fever, joint pain, but typical autoantibodies are usually negative.
Treatment for Cogan.
Topical steroids for the keratitis, systemic steroids, and maybe steroid-sparing agents for the vestibular or systemic issues.
Anything else in this variable group?
Briefly, pseudocanthoma elasticum is mentioned, and also exercise-related external iliac arteriopathy.
Ah, yes, the cyclist's condition.
Pretty much. Seen in competitive cyclists putting in really high mileage. The idea is that repetitive compression leads to fibrosis, thickening of the artery wall.
Causing claudication with exercise.
Right. Diagnosis involves checking the ABI ankle brachial index at rest and after exercise. Treatment can be bypass grafts or endarterectomy with a patch angioplasty. And the data suggests the patch might have better long-term results, less need for reoperation.
Rutherford also mentions vasculitis mimics, which is crucial.
Absolutely. Fibromuscular dysplasia, we'll get to that, and radiation arteritis.
Right, the late effect of radiation therapy.
Yeah, you have to remember that radiation for cancer can cause stenosis or even aneurysm formation in nearby large arteries. And sometimes it doesn't show up for decades after the treatment.
Which vessels are most susceptible?
Often the cervicocranial vessels, neck and head visceral arteries in the abdomen, and the iliac arteries.
And finally, secondary vasculitis.
Right. This is vasculitis triggered by something else. Could be infections like syphilis, a whole range of medications, chemo drugs, growth factors, even some common ones like certain diuretics or antibiotics.
Hydralazine, minocycline.
Exactly. Also, cancer itself can trigger it, and Rutherford briefly touches on vasculitis occurring within other systemic diseases like lupus or rheumatoid arthritis. When that happens, it often signals a more aggressive form of the underlying condition needing prompt, potent treatment.
Okay, wow. That's a comprehensive overview of vasculitis from Chapter 138. Now let's focus in on Chapter 139, which is dedicated entirely to thromboangiitis obliterans, Buerger's disease.
Right. So Buerger's is distinct. It's inflammatory, non-atherosclerotic, and it causes occlusion blockage of small and medium-sized arteries and veins. Primarily in the lower arms and legs, the infrapopliteal and infrabrachial vessels.
And the classic patient profile.
Classically, it's young men who are heavy smokers, though unfortunately we are seeing it more in women now as smoking patterns have changed. Geographically, it's more common in places like the Middle East and Asia. Relatively rare here in the West, thankfully.
Pathologically, what makes Buerger's different?
Well, you find this highly inflammatory clot, a thrombus, inside the vessel, but and this is key, the actual layers of the vessel wall, including that internal elastic lamina we mentioned, they stay intact. That's a big difference from atherosclerosis.
And it doesn't just affect arteries.
No, it often involves the adjacent veins and even nerves. Interestingly, despite being inflammatory, standard blood tests for inflammation markers or autoantibodies, they're typically normal.
So how does it present clinically? What should make you think of Buerger's?
The picture is often quite suggestive. You've got a young smoker, usually under 50, presenting with distal extremity ischemia, so pain in the arch of the foot or the calf when walking, claudication.
Coldness, burning pain.
Yes, coldness, burning pain, maybe that reddish look to the foot when it's hanging down dependent rubor, and also that migratory superficial thrombophlebitis called phlebitis sultans, where you get inflamed superficial veins popping up in different spots.
Raynaud's can be part of it too.
Raynaud's is common, yes. Sensory changes too. And in the acute phase, the affected arteries themselves might feel tender and thickened, sort of indurated.
Diagnosis sounds tricky if the standard inflammatory markers are normal.
It can be. There's no single definitive test, unfortunately. Rutherford goes through several proposed diagnostic criteria sets, Shinoya's, Papa's, Mills, Olin's. They all emphasize ruling out other causes of atherosclerosis, except smoking.
In the physical exam?
Often reveals diminished or absent distal pulses. An abnormal Allen test in the hands is also suggestive if upper extremities are involved.
What about non-invasive testing?
Things like reduced toe or finger pressures, abnormal PVRs, pulse volume recordings. Digital plethysmography can be abnormal. Plain X-rays might show an absence of arterial wall calcification, which you'd often see in atherosclerosis. And duplex or angiography might show those characteristic corkscrew collaterals Martorell's sign.
Angiography itself.
Angiography typically shows segmental occlusions, mostly distal, involving the digital arteries, while the proximal arteries look surprisingly normal. You might see those corkscrew collaterals again. But even these findings aren't completely pathognomonic unique to Buerger's. So ruling out other things, especially embolic sources, is critical. Cardiac workup is important.
Okay, so treatment, what's the absolute number one thing?
Smoking cessation, full stop, absolutely critical. Without it, frankly, nothing else is likely to work long term.
And beyond that, medical therapies.
Iloprost, which is an intravenous prostaglandin, has shown good results. Cochrane reviews suggest it's better than aspirin for healing ulcers and relieving pain. Other meds like silistazole might have a role. Prostaglandins, endothelin receptor antagonists, maybe even thrombolytics in some acute situations. And of course, adequate pain control is essential.
What about procedural interventions?
Regional sympathetic blockade, injecting anesthetic near the sympathetic nerves, or even spinal cord stimulation can be considered for severe pain or persistent symptoms.
Surgical options.
They're often limited because the disease is so diffuse in the small distal vessels. Lumbar or thoracic sympathectomy, surgically cutting the sympathetic nerves, can sometimes help, but even there, some randomized trials have shown IV Iloprost might be superior.
Bypass surgery.
Very challenging. Finding a suitable distal target vessel is tough, and the patency rates aren't great. If you do attempt it, using the patient's own vein graft is preferred, but only in highly selected cases.
Any other surgical approaches mentioned?
Yeah, more experimental things like pediculed omental grafts, using tissue from the abdomen to bring blood supply, or distal venous arterialization, basically creating an AV fistula distally to try and push blood into the tissues. Local wound care is obviously vital.
Endovascular.
Subintimal angioplasty, creating a channel under the artery lining, is showing some promise, but definitely needs more validation.
And newer therapies.
There's mention of immunoadsorption, growth factors, and importantly, stem cell-based approaches. Autologous bone marrow mononuclear cell therapy has shown some encouraging early results for limb salvage and pain relief in really severe cases. It's an area to watch.
And Rutherford includes a helpful algorithm.
Yes. The chapter concludes with a practical algorithm summarizing the diagnostic and treatment approach, which is really useful for quick reference.
Okay, great. Let's move now to chapter 141. This deals with aneurysms caused by underlying connective tissue abnormalities, specifically Marfan syndrome, vascular Ehlers-Danlos, and Loeys-Dietz.
Right. 3 major players here. Let's start with Marfan syndrome, or MFS. It's a relatively common inherited disorder, maybe 2 to 3 per 10,000 people.
Inherited how?
Usually autosomal dominant, caused by a mutation in the fibrillin-1 gene, FBN1, though sometimes it's a new de novo mutation, no gender preference. Interestingly, maybe a slightly higher incidence in tall athletes.
And the underlying issue?
It's a defect in fibrillin-1, which is a key part of connective tissue microfibrils. This also messes with TGF-beta signaling, which is important for tissue development.
Clinically, Marfan has quite a range of features, doesn't it?
It really does. Diagnosis uses the revised Ghent criteria. These look at major and minor findings across different systems: skeletal, eyes, cardiovascular, skin, lungs. Genetic testing for FBN1 can help confirm it.
And the biggest worry is the aorta.
Absolutely. Aortic aneurysm and dissection are the most serious complications.
Yeah.
So lifelong surveillance is key, usually with echocardiography. If echo views aren't great, then CTA or MRA.
How do you monitor in kids?
We use Z-scores, which account for body size, when tracking aortic root diameter. Rapid growth or significant aortic regurgitation might trigger earlier surgery. In adults, the general threshold for repairing the aortic root is usually a diameter over 50 millimeters, maybe earlier if there's a strong family history of dissection.
Medical management, what helps?
Beta blockers are standard. They reduce the force of blood ejection, the shear stress on the aortic wall. Studies show they can slow down how fast the aorta grows.
What about ARBs, like Losartan.
Angiotensin receptor blockers, yeah. Losartan showed promise in mouse models, and clinical trials suggest it might be about as effective as beta blockers. There's some thought it might offer extra benefit in preventing type B dissections, but more data is needed. Calcium channel blockers, generally avoided, not shown to be helpful for the aorta.
And surgery, besides the 5-centimeter root threshold.
Right. For aneurysms elsewhere in the aorta, like the descending thoracic or thoraco-abdominal aorta, standard thresholds used for atherosclerotic aneurysms usually apply. One really important surgical point, though. When dealing with the visceral and renal arteries, try to avoid using large inclusion patches on the graft. Individual bypasses, maybe using a 4-branch graft, seem to have better long-term patency.
Good tip. Okay, next up, vascular Ehlers-Danlos syndrome, VEDS. This is different from other EDS types, right?
Very different and much more severe. This is EDS type 4. The key issue is extreme vascular fragility due to defective type 3 procollagen from mutations in the COL3A1 gene.
And the natural history is grim.
Sadly, yes. Life expectancy is significantly shortened, often with major complications hitting before age 40. Vascular rupture is the most common cause of death.
How do you diagnose it?
It can sometimes mimic other connective tissue disorders, but the major criteria are pretty indicative. Easy, extensive bruising, thin, translucent skin where you can almost see the veins, characteristic facial features, and a history of arterial, uterine, or bowel rupture. Having any two of those is highly suggestive. Definitive diagnosis needs specialized collagen testing or COL3A1 gene analysis.
And non-vascular risks.
Yes, spontaneous tears in the GI tract, especially the sigmoid colon, are a risk. And uterine rupture during pregnancy is a major concern.
So managing the vascular complications must be incredibly challenging.
Extremely. Arterial rupture, dissection, pseudoaneurysms are common. Surgery requires incredible caution. You have to handle tissues so gently, be meticulous with hemostasis, limit dissection as much as possible.
What about endovascular actions?
Endovascular approaches, like coil embolization for bleeding branch vessels, might have a role sometimes. But even just getting arterial access is risky. You can cause a rupture or pseudoaneurysm right there. Sometimes you need to surgically repair the access site itself. Stent grafting, very limited use because the arteries are just too fragile.
A really difficult condition.
Yeah.
Okay, finally in this chapter, Loeys-Dietz syndrome, LDS.
Right. This is caused by mutations in TGFBR1 or TGFBR2 genes, again, related to that TGF-beta signaling pathway we mentioned with Marfan's.
How does it differ clinically from Marfan?
There's overlap, like aortic aneurysms, but LDS has some distinct features: marked arterial tortuosity, very twisty arteries, certain craniofacial abnormalities like widely spaced eyes, hypertelorism, cleft palate, or a bifid uvula. Unlike Marfan, they typically don't have lens dislocation. And critically, the aortic aneurysms in LDS tend to be more aggressive. They can rupture or dissect at smaller diameters than in Marfan.
So lower threshold for surgery.
Definitely. Repair is often recommended when aneurysms reach 4 to 5 centimeters, or if they grow more than half a centimeter in a year. Surgically, similar to the advice for Marfan's, there's a preference for directly anastomosing grafts to the origins of visceral and renal arteries, avoiding those large inclusion patches.
Surveillance.
Lifelong. Baseline head-to-pelvis MRA or CTA at diagnosis is crucial. You need to visualize the whole vascular tree, ideally every couple of years, or more often depending on findings. And type B dissections need very aggressive monitoring.
Surgical considerations for LDS.
Be aware of that tortuosity and possible unusual artery origins. Meticulous technique, limit aortic clamping, avoid extensive dissection, maybe consider wrapping grafts for support, and again, absolute priority on hemostasis. Those tissues can be fragile too.
Okay, that covers the major connective tissue disorders affecting aneurysms.
Yeah.
Let's move to chapter 142, Raynaud phenomenon.
Right, Raynaud's, that episodic digital vasospasm, fingers and toes turning white, then blue, then red, usually triggered by cold or stress.
And it's classified as primary or secondary.
Exactly. Primary Raynaud's is basically idiopathic, no known underlying cause. It's usually benign, no structural vascular changes. Secondary Raynaud's, though, is associated with some underlying disease process that does cause structural obstruction or abnormalities in the vessels.
Why do our digits react like this anyway?
Well, blood flow in the digits has two main jobs: thermoregulation, helping control body temperature and providing nutrition to the tissues. Raynaud's is essentially an exaggeration of the normal vasoconstrictive response to cold.
And the causes of secondary Raynaud's.
Yeah.
Lots of them.
Oh yeah, an extensive list. Connective tissue diseases are probably the most common culprit, especially scleroderma.
Scleroderma, right.
Also occlusive arterial diseases, atherosclerosis, Berger's again, GCA, emboli, thoracic outlet syndrome,
Mm.
occupational exposures like vibrating tools, certain drugs, hematologic disorders, even some cancers have been linked.
Pathophysiology, but what's going wrong at the vessel level.
It's basically an exaggerated vasoconstriction and impaired vasodilation. In secondary RP, factors like increased endothelin-1, a vasoconstrictor, reduced nitric oxide, a vasodilator, maybe increased sensitivity of alpha-adrenergic receptors, and angiotensin-Soddy effectnix can all play a role.
Diagnosis. How do you confirm it and tell
Yeah.
primary from secondary?
Diagnosis relies heavily on the patient's history, those characteristic color changes triggered by cold or stress. We use certain criteria to distinguish primary bilateral involvement, no tissue necrosis, from secondary. A thorough physical exam, including looking closely at the nail fold capillaries, nail fold capillaroscopy, is important.
Lab tests.
Labs like ANA, RF, ESR can help screen for underlying connective tissue diseases or inflammatory conditions. And non-invasive vascular tests can be useful too, measuring digital pressures, temperature recovery, or using laser Doppler before and after a controlled cold challenge.
Medical management starts with lifestyle.
Absolutely. Avoiding triggers cold exposure, stress, using gloves, warm socks. And if the patient smokes, stopping smoking is essential, as nicotine is a vasoconstrictor.
Medications.
Calcium channel blockers, like nifedipine, are often the first choice. Meta-analyses and Cochrane reviews suggest they offer a modest benefit, maybe more so in primary RP.
Other options.
Alpha-adrenergic antagonists have had mixed results. Prostaglandins and their analogs, like IV iloprost, can be very effective for severe ischemia or digital ulcers, particularly in secondary RP like scleroderma. Phosphodiesterase inhibitors, like sildenafil, have shown some promise in reducing attack frequency and duration. Endothelin inhibitors, like bosentan, are approved for preventing new digital ulcers in scleroderma patients. And topical nitrates can sometimes help.
What if medical management isn't enough? Surgical options.
For severe upper extremity Raynaud's, especially secondary cervical or thoracic sympathectomy can be considered. It can provide long-term relief for a significant portion of patients. Lumbar sympathectomy is the equivalent for the lower extremity.
More localized procedures.
In really refractory cases with tissue loss, adventitial stripping of the hand or digital arteries, removing the outer layer of the artery, is sometimes tried. And nerve stimulation techniques like TNS or spinal cord stimulators might help with pain and ulcer healing in severe secondary RP.
Any alternative therapies?
Acupuncture has shown some potential benefit, particularly in studies looking at primary Raynaud's, worth considering for some patients.
Okay, good overview of Raynaud's. Let's wrap up with our final chapter, 143, focusing on fibromuscular dysplasia, FMD.
Right, FLD. This is a non-atherosclerotic, non-inflammatory vascular disease. It causes stenosis, narrowing, occlusion, blockage, or aneurysm formation.
It affects which arteries?
Various ones throughout the body, but it predominantly affects women. The renal arteries and the carotid vertebral arteries in the neck are the most common sites. Sometimes it's found alongside other conditions like EDS the fee, Morphen's, or Takayasu arteritis.
Pathologically, what's happening in the vessel wall?
It's classified based on which layer is primarily affected: intimal, medial, or adventitial fibroplasia. Medial fibroplasia is the most common subtype.
And that gives it the classic angiographic look.
Exactly. Medial fibroplasia often causes that characteristic string of beads appearance on angiography due to alternating areas of stenosis and small aneurysmal dilation. Other types, like intimal or adventitial, might cause more focal, smooth stenosis.
Natural history. Is it always progressive?
It's quite variable. Some people are completely asymptomatic and is found incidentally. Others have progressive disease leading to significant symptoms.
And the symptoms depend entirely on where the FMD is located.
Precisely. Renal artery FMD is a major cause of secondary hypertension. Especially in younger women, it's actually the second most common cause of renovascular stenosis after atherosclerosis. Carotid or vertebral FMD can cause headache, pulsatile tinnitus, the whooshing sound, TIAs, or stroke. Mesenteric FMD can cause abdominal pain after eating. Extremity FMD can cause claudication.
How do you diagnose it? What imaging?
Non-invasive imaging like duplex ultrasound, MRA, or CTA is usually the starting point, but they can sometimes miss FMD, especially in smaller branch vessels.
So the gold standard is still?
Intra-arterial digital subtraction angiography, DSA, is still considered the gold standard for confirming the diagnosis and really visualizing those characteristic patterns like the string of beads. Plus, during DSA, you can measure the pressure gradient across a stenosis to see if it's hemodynamically significant.
Let's focus on renal artery FMD first. Big cause of hypertension.
Right. Young Caucasian women are the typical demographic. You should think about evaluating for secondary hypertension and potentially FMD in patients who develop hypertension young or have sudden worsening of previously controlled blood pressure or hypertension that's really resistant to multiple medications. Rutherford provides a useful box outlining these indications.
Treatment, medical versus mechanical.
Treatment choice depends on severity of hypertension, symptoms, etc. But for significant renal artery FMD causing hypertension, percutaneous transluminal renal angioplasty, or PTRA, is the primary mechanical treatment.
Balloon angioplasty, basically.
Exactly. Usually accessed via the femoral artery. You dilate the stenotic segment with a balloon. The key is not to oversize the balloon to avoid causing dissection or rupture, which are potential complications.
How effective is PTRA?
It can be very effective, especially for single focal lesions. Cure rates for hypertension can be quite high in those cases. But restenosis can happen, so ongoing surveillance, usually with duplex ultrasound, is needed.
When would you consider surgery for renal FMD?
Generally reserved for cases where PCRA fails isn't technically possible, or maybe if there are complex lesions like large aneurysms associated with the FMD. Surgical options include aortorenal bypass or sometimes direct reimplantation of the renal artery onto the aorta.
What about kids with renal FMD?
Interestingly, in pediatric renovascular hypertension due to FMD, direct anastomosis to the aorta is often preferred over using vein grafts if surgery is needed.
FMD associated with aneurysms,
Right.
high rupture risk.
Generally, the macroaneurysms sometimes seen with FMD have a relatively low risk of rupture compared to atherosclerotic aneurysms. But treatment, either endovascular or open, is usually considered for larger ones, say over 2 centimeters.
Okay, now turning to FMD in the neck arteries, extracranial, carotid, and vertebral.
Right. This can present with neurological symptoms, headache, pulsatile tinnitus, TIAs, occasionally stroke. Again, diagnosis often involves MRA or CTA showing that string of beads, or maybe just a focal stenosis.
Treatment seems complex here.
It does present challenges. You might have FMD in other arteries too, like the renals causing hypertension. The contralateral carotid might be affected but asymptomatic. Symptoms can sometimes be nonspecific, and there's an association between cervical artery FMD and intracranial aneurysms, which needs separate consideration.
So when do you intervene?
Generally, intervention like angioplasty is considered for patients who've had focal ischemic events, TIAs, or strokes clearly attributable to the FMD lesion, or maybe if there's evidence of significant hypoperfusion causing symptoms.
Even if you do angioplasty.
Cerebral protection is usually employed. That might mean using distal filters to catch debris or flow reversal techniques during the procedure to minimize stroke risk. It can be done via transfemoral access or sometimes via a small incision in the neck, transcervical.
What about asymptomatic carotid FMD?
Medical management, typically with antiplatelet agents like aspirin, is the usual approach for asymptomatic lesions. So as we've covered, it's quite a diverse landscape, isn't it? This whole area of non-atherosclerotic arterial disease, from inflammation and vasculitis to the smoking-linked burgers.
To the genetic connective tissue disorders causing aneurysms, the vasospasm of Raynaud's, and these structural arterial issues in FMD.
Exactly. It's a broad spectrum.
And, having a really solid grasp of these conditions is just so essential for vascular surgeons, wouldn't you say?
Couldn't agree more. Accurately diagnosing them, tailoring the management, which is often quite different from standard atherosclerotic disease, that's absolutely paramount for getting good patient outcomes and preventing some really serious complications.
Yeah, it really highlights the breadth of vascular surgery beyond just plaque.
It really does. So we definitely encourage you, the listener, to perhaps revisit these specific chapters in Rutherford's for even more detail and maybe reflect on how these insights might, refine your own approach when you encounter patients presenting with these less common but really critical arterial problems.
Absolutely. And maybe a final thought to leave everyone with. With all the rapid advancements we're seeing in genetics, in sophisticated imaging, how do you think our understanding and maybe ultimately our management of these complex non-atherosclerotic diseases will continue to evolve in the years ahead?
That's the big question, isn't it? Personalized medicine is likely coming to this area too. It's an exciting, if challenging, field.
Definitely something to keep watching. Well, that concludes this deep dive. Join us next time for another in-depth exploration of a crucial area in medicine.